Um, are you all right with the recording?
Yeah, sorry, it was giving me.
Okay. Our next faculty development session will be in October, and that will be Dr. Shipman is going to talk about sustainability or environmental impact of the operating room and what we do. So we will look forward to that presentation. All right, I'm going to share. Rebecca, tell me if it looks right.
Looks good.
Looks good. Okay. All right. So I have a mandatory CME slide. I have nothing to disclose, although with a caveat that I'll get back to later. So surgical ergonomics is defined as the science, it's an industrial science, and it's the science of designing and arranging workplaces, products, and systems so that they fit the people that use them. Specifically, it aims to make tasks and environments safer, healthier, and more comfortable, hence leading to more productivity for individuals. So it's kind of a two-pronged science, one looking at increasing output, increasing productivity, as well as increasing the wellness or the health of the worker. So why do we care about this? Because it's a problem in surgery. We all know that surgery is a full contact sport. Not just the mental rigor of keeping people healthy and saving lives, but also the physical work in the operating room. And sometimes that is fine motor skill work. So you're talking about, very fine movements of your fingers and your hands. But also we all know that, in a world of, robotic surgery and laparoscopic surgery, and even in some open surgery, there's significant physical effort involved in this. And so recently this has become an issue because we've been looking at wellness of surgeons and longevity of surgeons, and the impact that this has physically on your body. And very often in the literature, they compare surgeons to high performance athletes. That really this involves the investment of your physical body. And we unfortunately don't always think about it that way. We don't train necessarily the way precision athletes do, high performance athletes do. And we certainly absolutely don't take care of ourselves. So, in looking at the scope of the problem, there was a meta-analysis done in 2018 in Annals that looked at 41 articles, more than 5,100 surgeons, that demonstrated, the most common physical complaints of surgeons from operating, either pain from the pain in the operating room or thereafter, included back pain, neck pain, arm and shoulder pain, fatigue, muscle fatigue, numbness, and stiffness. In 2017, a different analysis showed that up to 90% of surgeons experience pain in their back, neck, and hands, and almost 28% reported chronic pain or an injury. And this is, kind of makes sense that years of standing in the OR for long procedures, often we are contorted into static positions for long periods of time. Nearly always the surgeon will sacrifice their own body to avoid putting stress on the patient. We see that a ton in bariatrics. We all have the patient supine and stand on the side of the table, which involves twisting and leaning over the table, versus put the patient at risk, which is, the other option is to put them in a beach chair configuration, but that increases the risk of injury to the patient. And so often we will sacrifice ourselves in order to ensure that patients don't get injured. This ergonomists have looked at the prevalence of this and how this compares to the general population. Certainly, we have a much higher risk of work-related musculoskeletal disorders than the general population. But when they look at very labor-intensive occupations, things like coal mining, manufacturing laborers, so factory workers, physical therapists, our risk of workplace injury is on par with those very high risk physical populations. So this is really a thing, and the higher risk surgeons are those doing minimally invasive surgery, both robotic and laparoscopic, endoscopic surgery, because of the high impact on the shoulder girdle and the wrist. As well as women surgeons, and I'm going to get into that a little bit more later, and that has to do with sort of the physical makeup as well as the matching between the available equipment and the body habitus of female surgeons who tend to be a little bit smaller, have smaller hands. They tend to have a little bit less muscle mass, and they tend to have to use different muscle groups in order to get the job done with the equipment at hand. So high rates for work-related musculoskeletal disorders. These can be dependent upon a lot of factors. A lot of factors contribute to this. One, as I just mentioned, is essentially violating principles of ergonomics. Having your monitor too high so that your head is always looking up. When I was a medical student, I recall operating with some vascular surgeons who basically all had, a hunchback because they were all sort of huddled over, looking down through their loops at the table, leaning over the table like I do in order to operate on a bariatric patient. So all of those things are straight up in violation of ergonomic principles. The instruments, while industry thinks they do a good job of designing instruments, industry generally is in the business of one size fits all. And when they are designing instruments, they sort of go with what historically has worked. They design instruments for large swaths of the population that are not necessarily tailored to specific groups of people. Um, Digitization of non-work tasks. So what that means is, like, yes, you're operating and you're working very hard physically, and then you go sit at your computer and do very static, non-mobile work, so that you're not stretching and building muscle mass. You're sitting and actually with the transition to the EMR, more and more we're seeing, especially in like primary care doctors, they're getting carpal tunnel syndrome from just like secretaries and administrative assistants do from all of the typing. But for us, because we're not up and moving around and stretching those muscles, it increases our risk of injury. The surgical culture is a big piece too, and it's kind of the crux of what I'm going to try and get at today. And that is, since back in the days of Halstedian design of training programs, surgery is kind of designed to be hard because our job is hard, and we want to make sure that our trainees understand that our job is hard and that you're going to have to face challenges and you're going to have to have grit and endurance. But what that also trains our trainees and all of us is that it's kind of like the royal family, like never complain. So you don't complain to your operating room leadership about the setup of your room or the towers that have the monitor up at 6 feet in the sky. In my room, we just got the boom fixed, so I can move the boom around, but it took 2 years to get that fixed to help with the ergonomics. And as a trainee, you don't feel like you have a lot of power in the operating room. And so very often they will not ask for accommodation. They won't ask to have the monitors moved. They won't ask to use different instruments. They won't tell you that it hurts me to use that. And so it's just kind of built into our culture that you just kind of suck it up. And that over the long term leads to injuries. Adjuncts that we use in the operating room, things that really are not part of your normal body habitus can really throw off your balance. So using things like headlights. Well, the headlight, adds additional weight to your head. Sometimes the headlights are very heavy, especially the older ones. They've got that fishtail off the back that plugs into the light box. That sort of limits your head movement. Alternatively, there's some headlights that have battery packs, but those are even heavier to wear. And then when you're operating, you need to get your headlight light into your operative field. And so your head is immobilized for a long period of time, but that may not be in the most ergonomic position. Loops are another one. Again, you're trying not to move your head around too much so that your field is in focus. There's a one study that shows that like 80% of loops, even though we get them expertly fitted by the company that we buy them from, 80% of loops are not really appropriately designed for a focal length, and essentially nobody ever gets their loops ever adjusted. No one goes back to the company and says, I want to get them fixed. And they are heavy, and pull down on your head and increase your risk of neck injury. And then lead aprons, right? For those of us in vascular surgery, or those of us shooting a lot of cholangiograms, or those of us in orthopedic surgery, those lead aprons are heavy. The newer ones are lighter, but the old ones are heavy, and we have all old ones. And so the weight of carrying that lead around, especially for prolonged cases, does add additional toll to your body. And then workspace and time restriction. So, again, the boom was broken in 25, so that really sort of crowded up my workspace. We had to have the monitor plugged into the video box until we got that fixed. Down in the GI unit, they just redid the whole GI unit because one of those rooms was teeny tiny small, and so trying to work your colonoscope in that little tiny space, the workspace is restricting and physically stressful. And then, of course, we're all under productivity um, pressure. And so trying to get as much done as we can. Oftentimes, the things that go by the wayside are the things that involve making our workspace and our procedures more comfortable. So there's lots of impacts to ergonomics or bad ergonomics, and this isn't just a matter of whether or not you complain or ask for accommodation in the operating room, but this can affect lots of things, leading to discomfort in the operating room. If you are uncomfortable, you are less resilient, basically. You're sort of a little bit more likely to cut corners, be fatigued. You're more likely to be less reactive when something goes wrong because of your physical limitations. That can have impact on all of those things, can impact quality and safety, can lead to work-related injuries. Those things can impact on your communication and your teamwork. So if you're uncomfortable and you're in pain, you're sort of more likely to be crabby and not communicate with your team as well. That could impact on your willingness and your ability to teach. Again, if you're sort of confined to maneuvers that work well for you or cause less pain for you, you might be less willing to be adaptable to do things or consider doing things in a different way. All these things, we have the stress of what we do every day, of our administrative demands, of our productivity demands. And then on top of that, you had the physical stress of fatigue and pain in the operating room. That certainly contributes to a decrease in surgeon well-being and burnout. I will share with you guys that, when we do our anonymous ACGME survey in the spring, the core faculty also do an anonymous survey, and a piece of that survey is a wellness survey. And I will tell you that the attending faculty, their wellness is far less good. They are far less well than the residents are. So we spend a lot of time worrying about resident wellness because the ACGME holds our feet to the fire. But it's almost more concerning to me about the lack of wellness and the burnout in our faculty members. And that's really what we're role modeling for our residents. So it's kind of a catch-22 because we want to teach them how to be well, but we aren't taking care of ourselves, basically. All these things can contribute to reduction in productivity that impacts institutional finances, of course, and ultimately it can affect your career longevity. I know there's probably not too many of us out there on the Zoom who can raise their hand and say they don't have any joint pain. They don't have knee pain or shoulder pain or wrist pain. I know I was less than 2 years into my career when I started having rotator cuff problems that have now been injected a bunch of times. And, we all just kind of consider that sort of part of the job. But in a world that we are facing an impending surgeon shortage with the aging of the boomers, it takes a long time to train a surgeon. And so losing surgeons to burnout, losing surgeons to injury, that has a significant impact on not only our personal retirement plan, but it has an impact on our obligations to society. There is an organization, if you want to learn more about this. I swiped a bunch of these slides from the Society of Surgical Ergonomics, which is kind of a nascent group. They're just sort of getting going in the last couple of years. But on their website, they have, I didn't go into all the details about exactly where your monitor is supposed to be and exactly how high your chair is supposed to be if you're a robot surgeon. But there's a bunch of diagrams on that website. Also, there's a bunch of pictures and sort of programs around stretching and micro breaks in the operating room. So if you're interested, please check out this website for the Society for Surgical Ergonomics. This is a topic that's become a big topic at national meetings. I saw a session on this at the Clinical Congress last year. There was a session on this at SAGES last year. So this is an up and coming topic. So what about our trainees? You think they're young and like, your kids, they're unbreakable and bounce easily. But it turns out not so much. There's a couple studies out there looking at workplace injuries in trainees. And by the way, when we talk about workplace injuries, far and away, work-related musculoskeletal disorders outweigh things like workplace violence. Like people who get injured at work in healthcare are usually injured because of repetitive tasks and musculoskeletal disorders. So I looked at some plastic surgery trainees. 92% of plastic surgery trainees reported physical pain in the operating room, and the majority of them reported that these symptoms were onset within their first 2 years of training, which is interesting because we all sort of know that the first 2 years of training is when you're not operating that much. So it doesn't take that much operating for these symptoms to appear. Other location is, of course, very similar to practicing surgeons, neck and back, arms, shoulders, wrists. And it's important because early on in training is when they're developing muscle memory, right? And so if they're learning to do things ergonomically incorrectly, and they're developing that muscle memory around these maladaptive practices, that's what can lead to long-term problems. And so early intervention, teaching of these things in the operating room, formal training on these things, and advocacy to protect them may show some long-term benefit if we correct the muscle memory that they're learning to advocate for the things that protect them. And looking at general surgery residents, again, the numbers are there, right? 85% experience pain. We also see stiffness, numbness, weakness. And you can see, 55% of them were having symptoms in their first year. There's a learning curve in surgery, we all know, where they're very, very focused on their specific assigned tasks in the operating room. That requires extreme mental preparedness, like understanding the underlying pathophysiology of the patient, understanding the operation that we're going through. And so the operating room is a very stressful place for trainees without these issues. And so while they're trying to function in this stressful environment, again, they kind of put aside their physical discomfort as an accepted part of the learning process. And this cognitive load and mental and physical stress, it compounds basically to ensure that they're not really addressing the issues that make them comfortable in the operating room. And in this study, I think, again, going back to the culture thing, 65% of the residents reported the operating room culture and their relationship with the staff and the surgeon does not allow them to report the onset of symptoms or ask for adjustments in the OR to accommodate their physical comfort. So why? Like, why don't we know about this? They did a survey study in Annals in 2019 that went out to program directors in a bunch of surgical and interventional specialties. They completed a questionnaire, and what we found was that surgical ergonomics education is extremely rare. 1.5% of programs had formal education on surgical ergonomics. What they found was on occasion there'd be, a sporadic lecture here or there, or there'd be sort of informal teaching in the operating room. I'm constantly moving the bed up and down for my fellow who's like 2 feet taller than me. But formal education around this, both at the attending level and at the resident level, is relatively sparse. And so, we need to start looking at that. And the discussion is around, what kinds of things can we do to address this culture? And obviously, the first thing is the education piece, right? So that's what I'm starting with here today, just sort of an introduction to this concept. And I'm going to give a similar talk to the residents so that they know that we're having this conversation. It's important that we talk with the residents about their physical comfort. It's important that we encourage them to report pain and injuries early. These are workplace related things. I saw a study that showed that while all of these surgeons are having pain, and many of them are having injuries, essentially no, and oftentimes, like 35% of the time, it was impacting either choice of procedure, the modality of the procedure, or the number of procedures that could be done. But less than 10% of surgeons had reported to employee health that they had a workplace-related injury. And that has consequences for you down the road, right? You can't claim this as workers' comp. You don't get this addressed. You don't have the understanding that you need to get it corrected, that you need to go to physical therapy, that the time needs to be taken for that. And it just kind of looks like you're not getting your job done, right? It impacts on your productivity. So encouraging early reporting, having a person who's responsible for addressing this, whether it's the program director or a lot of this work is being done out of both Duke and Mayo, Minnesota, Mayo Rochester. They strongly advocate for an ergonomics champion, someone separate from the program director that residents can go to and talk to about either their ability to impact their operative environment or workplace-related injuries so that they can get them addressed. And they felt that it was important to have someone separate from the program director who's not sort of their boss, not somebody who's just looking at their effectiveness and their efficiency. Encouraging referrals to PT and OT, making time for them to go to PT and OT. After doing PT for a year after my ankle, I'll tell you that, it's not always easy to get people to understand that like that is a physical health priority. It's not just like a thing you're doing for fun to get out of work. You need to go to PT and you need to make sure they can get there. And this is all to prevent these symptoms from becoming either chronic symptoms or more significant injuries. I know some of you remember my former partner, Fred Benani, who had terrible rotator cuff problems that were unaddressed. And eventually he ripped his whole shoulder apart and had to be out of surgery for 6 months to get that surgically reconstructed. So addressing things when they're smaller things to prevent them from becoming much bigger career impacting things or career ending things. The board and the ACGME have recognized this as a silent but deadly issue that needs to be addressed. I don't know if you guys are aware, but SCORE is the surgical core. It's basically the overall curriculum for teaching surgery, teaching general surgery. It has like a billion modules about all the things they need to know, but they actually put a module in here on surgical ergonomics. It's under the practice management section. And so this is one of the, a couple hundred things that they have available to them and are expected to look at and understand. But it's important enough that the board has recognized that this is something that requires awareness and needs to be addressed. And so they did put a module on surgical ergonomics. So, okay, we all agree it's a problem. What can be done about it? As I said, first is awareness and education, which is what I'm hopefully starting to do here a little bit today. Like I said, I'm gonna do a similar talk to the residents so that they can start to have some awareness and education, and we can start talking about some of these things, looking at spreading best practices. Two is preoperative physical training and attention to wellness. So just like elite athletes who perform physically, if we're going to compare ourselves to them, they don't just, show up on race day and race. They prepare. And so wellness, well, we're always touting wellness, and that involves things like, eating a healthy diet and exercising. It sounds easy to say, right? It's like me telling patients, you just need to exercise more and eat less and you lose weight. It doesn't really work that easily. But really emphasizing that your physical wellness has impact on your ability to provide safe and quality patient care, that it's a personal obligation that you are physically well because we are in a physical job. That also may involve preoperative physical training. So for example, my new fellow starts tomorrow. And I know with a new fellow that they're not going to know how to laparoscopically sew. And so I'm probably going to be, hand sewing a couple of switches here over the next couple of months. So a couple months before the new fellow starts, I start weightlifting to make sure that my shoulders and my rotator cuffs are in shape so that I'll be able to do that without significant pain to me and without it taking forever with the patient on the table with the new fellow coming in. Of course, as they go through the year, they get better and I sew less. But that's, part of what I look at is what I need to do to prepare my body for the care that I'm going to be providing over the next couple of months. For some folks, that might mean, back exercises or core exercises, or stretching of, shoulders or wrists as you prepare for surgery. I've talked now a couple times about the culture piece. Expectation setting, making sure that the residents know or the trainees know that, when they are the operating surgeon, the room should be accommodated to them. And that means moving the bed to where it needs to be. That means moving the monitors to where they need to be. That means making sure that the chair that they're sitting in at the robot adjusts to the correct height for them, that the robotic training console is moved to the right place so that it fits their head, so that their elbows are resting and not floating, making sure that they understand that they should ask for those things. Once upon a time, when I was a junior resident, I had a nurse in the OR tell me that if I needed a step stool, I better put it next to the bed before I scrub because it's not her job to do that. Those are the kinds of things that, we as attending surgeons, as the people controlling the room, need to help out with that. Need to make sure that the residents, it's sometimes you need to be on a step stool if your attending surgeon is 2 feet taller than you. Making sure that the staff in the room understand that we're accommodating all of the surgeons in the room, not just the attending. Often our OR buys little tiny step stools that are, relatively easy to fall off of. And most of them have one or more of the little rubber feet on the bottom of the step stool missing, which means the steps slide around. So not only is it small and they're balancing precariously on it, but they slide around on the floor. So in my OR, we always put 2 step stools locked together. They have a little ridge on the side where you can lock them together, especially if they're going to have the pedal, the cautery pedal for the lap chole. The pedal goes on one step stool so the resident can stand on the other step stool. And we only use step stools that have all of the rubber feet on them. Because when you're, trying to carefully dissect around the gallbladder and you're perched on a stool that's moving around on the floor, that really adds an additional level of challenge that shouldn't need to be there. Optimizing your OR setup. I talked a little bit about the loops already and how they are limiting and can cause workplace injury. Another option for some specialties is a microscope, but that kind of comes with its own pile of problems. At least with loops, you can move your head around and change your focal points. The microscope is not hanging off your head, but the microscope is relatively fixed. And so they see more issues with just holding their head in a very specific configuration for long periods of time. I talked about headlights and the problem with headlights. Another option is lighted retractors, which as far as I know, we don't really have here. But that's an option that can be considered. I've worked some places with lighted retractors that work very well. And that's, essentially what anesthesia does with all their fancy new glide scopes, right? They all have lighted retractors. I talked about the aprons. I've talked a little bit about the chairs. There is industrial health data around floor mats. The floor in the OR is, of course, all tile, and it's really designed around durability and not designed around comfort. There's essentially no spring in the floor. But I know from the past, again, my former partner had floor mats in the operating room, and it was a really big problem, both with OR management as well as environmental services trying to get them cleaned. And they basically gave us a really hard time that while, yes, it's better for the surgeon and more comfortable for the surgeon, they don't want to clean them, basically, and is negotiating that road, making sure people have appropriate shoes. I think the nurses do a lot better job on this than we do. Sometimes the shoes that we pick are the shoes that slip on and off, and that can be thrown in a dishwasher or something because it'll wash all the blood off. But those might not be the most supportive shoes, and how well your feet are doing and how stable your feet are really has a lot of impact all the way through your axial skeleton on things like back pain, knee pain, hip pain. And then I know my vascular surgeons will applaud me for this, but the idea of wearing compression socks to try and prevent venous disease and leg fatigue. So I'm not going to go through all the details here, but just a couple of pictures to demonstrate that sort of no matter what kind of surgeon you are, ergonomics can have some impact on how you operate. They actually, in several of the recommendations, encourage that you have your OR staff sneak some pictures of you while you're operating. Because while you might think that you're standing up straight, while you might think that you're not slouching, while you might think that you're not excessively flexing your neck, you may well be and not even know it. So here's some pictures of sort of the mistakes that can be made, either the table being at the wrong height, the monitor being at the wrong height, the chair being at the wrong height, too much hunching, floating elbows, too much wrist flexion, all of those kinds of things can lead to injuries. Here in open surgery, again, standing on a tiny step stool with the cautery pedal and the table at the wrong height, too much hunching. And in the bottom right there, you can see my my former faculty vascular surgeons who are turning into the Hunchback of Notre Dame. So warming up, most elite athletes don't just show up at the field and then, start their race. Stretching, warming up the muscles that you're going to use. There's data that shows that decreases injury. Optimizing operative techniques and instruments. I'm going to get into this a little bit later, but as I already mentioned, things like, what position you put the patient in. Do I put them in supine position to protect the patient? Do I put them in beach chair configuration to optimize me? I'm trying to find some happy balance between those things so that you can't help anybody else if you hurt yourself. Optimizing instruments. I'm going to talk a little bit later about how some instruments really don't work well for some trainees, for some surgeons. And so optimizing those kinds of things for you and for your trainees. Seeking systems changes. I already talked a little bit about, getting the boom fixed, getting the ceiling mounted monitors so that they can pull to the right position, seeing if they can let us use the floor mats, those kinds of things. Getting instruments that they might say that they are reluctant to buy us. Reporting injuries and seeking treatment. Mandatory breaks and stretches. Mayo has a huge thing about this on their website. I encourage you to look at it. But they essentially demonstrated that taking micro breaks in the middle of surgery, and these are things that can be done while you are still scrubbed, to stretch and move around a little bit, to loosen up the muscle tension, to correct your posture. Their little program takes like less than 2 minutes, and they actually show that it did not increase operative time to do this. However, they suggested that this be essentially mandatory. That way, you decide on what time you want to do this, and they suggest like every half hour, the circulating nurse would say, "Hey, it's time for a break." Everybody would stop, do their 2 minutes of stretching, and then go back to work. If it's mandatory, it's more likely to happen. They offer that, yes, of course, if you're at a place in surgery where like now's not a good time, that it can be deferred a minute or 2 or 10 in order to get to a better place to stop. But they actually showed that their OR efficiency went up when they started enacting these mandatory breaks that were, essentially driven by the circulator because she's, can pay attention to the time. And when they surveyed the surgeons afterwards, there was an overwhelmingly positive response. Like 90+% of surgeons said that they felt it was beneficial. Many of them said that it decreased or eliminated their pain or fatigue post-surgery. So while it sounds a little goofy, there's a fair bit of pretty good data out of Mayo that shows that it works. And then lastly, probably the most challenging, but likely the most important piece would be partnering with industry in designing of instruments, probably instruments that are, not one size fits all, instruments that are designed to fit the body of the surgeon, as well as partnering with engineering in design of the procedural spaces. Oftentimes they design the OR space with relatively little input from surgeons, or they'll get input from 1 or 2 surgeons who don't understand the workflow or the workspace of a bunch of other surgeons. So we've all seen in the last couple of years, they did a big push on trying to restrict entry to the operating room. And for those of us who are in the LenFest side, coming in through the core, everybody's climbing over all of our sterile stuff to try and get into the room. I know they just did a massive construction project down in the GIPU to redesign one of the rooms down there. And I don't know who they talk to, but the way it's set up down there, you know, now you can sort of see straight into the room to the patient's backside from the waiting room. And if anybody had talked to me about that, I would have said I don't think this is going to work. So making sure that when an OR is being built or redesigned or any procedural area, that you get broad input from the stakeholders to make sure that the spaces are designed appropriately. I want to say one little piece about anatomic minorities, and this is the part where I'll add my disclosures. So I'm an anatomic minority in two uh, qualities. One is I'm a left-handed surgeon. About 10% of people in the world are left-handed. There is some variability in what's considered left-handed because there's some people who um, have what we call crossover, which means they do some things with their right hand. That's kind of how I am. But I'm also a small-handed surgeon. So small-handed is considered glove sizes of 6.5 or smaller. And then just in thinking about minorities, I'm thinking about other surgeons who sort of don't fit the physical norm that the room and the space and the instrumentation may be designed around. And that includes very short stature surgeons, very tall stature surgeons. You guys can imagine how funny it is when Jesse and I operate together. Either the table's way up high and I can barely see what's going on, or the table's way down low and he's hunched over. Surgeons with very short arms who can't sort of reach over their field. And then colorblind or depth perception impairment surgeons may have issues with regards to especially minimally invasive surgery, and they may self-select out, I would imagine. But these are all kinds of things that I thought ought to be considered in thinking about how, you know, every surgeon is not the same, every trainee is not just like you, and that, you know, you as the teacher should consider adapting to these things. I don't know how many surgeons out there ask the trainee when they come in the room if they are left-handed or not. When I trained at Penn, nobody ever asked me, and when I did ask about getting some left-handed instruments, I was told that the nurses would have to flash them for me every time. They're not going to do that, so I'm going to learn how to sew right-handed. So I now sew predominantly with my right hand, even though I'm left-handed dominant. The interesting thing about left-handed people is that we have spent our whole lives accommodating to a right-handed world. You know, in kindergarten, there was like one pair of left-handed scissors, so we've all learned how to cut with our right hand. That is likely why there is a larger proportion of left-handed people who are minimally invasive surgeons, because we are a little more ambidextrous generally, and left-handed people often don't recognize the overcompensation, the additional degree to which they have to work to recognize that this is harder for me than it is for other people because we've just had to do it like forever. But this can have impact on trainees who have not really accommodated to the operating room yet. And there are options out there for how instruments and even procedures can be adapted to residents that are left-handed. So, you know, when I do a gallbladder, I dissect with my right hand, I'm retracting with my left hand. If you are left-handed, it's entirely possible that you don't have necessarily the fine motor skills in your right hand to do the dissection right-handed. So I have very often flipped the gallbladder and retracted it to the right and been able to do the dissection with my left hand. There are options for accommodating procedures like that out there that are often not recognized by the majority right-handed surgeons. Small-handed surgeons also face a lot of challenges. While these surgeons are more often female or smaller Asian men, you know, hand size in humans is hugely variable. When you talk to industry, they essentially equate glove size with hand size, which is not, it's sort of the best metric they have. It's kind of like BMI. It's kind of a ballpark metric. But glove size is very dependent on the wearer and how tight they want the gloves to be. Glove size has a lot more to do with finger length than palm length. There's also significant differences between operators on grip strength. And the size of your palm has a lot to do between your thenar eminence and your hypothenar eminence with your ability to grip things. I'll come back to that in a second. And so generally the industry convenience samples, you know, they like to say that they tried their instruments in a diverse group of surgeons. They like to say that they included a bunch of women, but really sometimes the only metric that they have is glove size. And even that, sometimes they can't provide. I recently asked Ethicon if they could provide me anthropomorphic data on glove size for the convenience sample for the new power echelon that they put out, and they can't find it. They can't find it for me. And I'm going to show you in a second why I hate that stapler. So the most common instruments that small-handed people have issues with are what's pictured here. And just as an FYI, we have, I think it's like 15 or 16 residents between OBGYN and surgery who wear size 5.5 gloves or smaller. So you're talking about very small-handed people. And in our operating room, up until about 2 years ago, they refused to stock size 5.5 gloves. They basically would buy a box of 5.5 because there was already too much stuff in the operating room. They would give the trainees a box of gloves and say, put this in your locker and you bring your own gloves to surgery. And I cannot tell you how inappropriate that is. That's basically making second-class citizens out of them and making them responsible for providing their own equipment to the operating room. So all of the ORs should now be stocked with size 5.5 and 6 gloves. And if they're not, you need to say something and make sure that your small-handed surgeons, your small-handed trainees are not being treated like second-class citizens. So these instruments, as you can imagine, if you look at this this open harmonic, the ability to stretch your hand that far to open that instrument and then be able to provide the grip strength when your hand is stretched like that, your ability to provide grip strength is significantly diminished, and it requires a significant more effort. The endoscope, I say to the residents all the time, like, imagine what a great endoscopist I would be if I could even reach the little wheel on the endoscope. There are smaller endoscopes out there in the universe. I have never seen a facility that purchased any of them. And so there are accommodations that I do to be able to use the endoscope. Things like I put the bed way up high so that I can rest the scope on the bed so that I don't have to have my right hand constantly on the scope. I oftentimes are resting the scope up against my chest to kind of hold the wheels in the right place because I can't fixate both of those wheels. But if your hand is so small that your fingers are like essentially required to hold the scope against your palm, it significantly limits the mobility of your thumb. And that is my major complaint about the new Echelon stapler. For those who haven't seen it, instead of pulling on the spin wheel and pushing against something to articulate that stapler, they've now moved the articulation function to basically electronic buttons on the handset. But again, if for a lot of folks with larger hands, the cupping motion of your palm is enough to keep the handle of the stapler in your hand. For small-handed people, my fingers have to be curled around the handle to hold it in my hand. And what that means is that my thumb has to oppose, and my fingers are really not free. If I let go with my thumb or my index finger to try and work those up and down buttons, the stapler is no longer stable in my hand. And so that instrument is really not functional for me. And I am not using it, although I expect someday that my stapler is going to go away and I'm going to have to. The laparoscope, very similarly, we all use angled scopes. You have to move the light cord around to change the angle on the scope. Well, for small-handed people, their index finger can't reach out and turn that light cord. It's a two-handed maneuver to be able to change the angle on the light cord. So it's not as easy as it is for some folks with larger hands, like Michael, my PA, can just reach out with his index finger and flop the cord over. I can't do that. I have to let go with whatever my left hand is doing and move the light cord around and change the angle. And even with open instruments, first of all, essentially all open instruments are designed to pop to release the ratchet with the thenar eminence. For us left-handed people, that's really annoying because it's got to pop the opposite way basically, and so trying to push the instrument with your hypothenar eminence is very challenging. Oftentimes the rings are pretty far apart, and so I've actually seen a chief resident who wears size 8 gloves trying to teach a med student who wears size 5.5 gloves how to palm an instrument to sew, and that's just really very, very challenging to hold the instrument in your palm and sew if you have very small hands. Also, keep in mind that if you're not palming and you're putting your fingers into the rings, their fingers are often very much farther into the rings than they would be for a larger handed surgeon, and that can actually restrict your motion. It can, when we're all telling them to turn your wrist, swing your wrist, your ability to swing your wrist sort of has to do with how far your fingers are into those holes. And so, again, we're not going to save the world and solve all these problems here today, but I just want to make you guys aware of some of the anatomic restrictions and challenges that people who might not be like you might be facing. And so, what can we do about this? What are the consequences of this? As I mentioned, sometimes you need compensatory maneuvers. That might, like I said, putting the bed all the way up to put the endoscope on the bed. That might mean that maybe I need to open a longer harmonic to be able to get to where I need to go. Maybe I need to, move the tissue differently so that I don't have to swing my wrist so far because I can't get that far with my fingers in the holes. It restricts my degrees of freedom. It involves activation of accessory muscle groups, as I mentioned. So women, they actually did EMG studies. Small-handed women activate more muscles in their shoulder girdle and in their forearm when they are sewing than other surgeons do. This can lead to increased muscle exertion and stretch. That can lead to injury. This can lead to, as I mentioned, if they're struggling with the instruments, it's hard to multitask and learn the procedure. These things can lead to decreased efficiency, longer OR times, less economy of motion, fatigue, loss of precision. As I said, when you're tired and you're struggling, your reactivity to changing scenarios can decrease, so that can restrict your ability to respond to unanticipated events. If I have a problem with my anastomosis and I have to take it all down and redo it, like I'm exhausted now. Like it's very, very difficult for me to redo an anastomosis. So do I cheat and hope for the best, or do I take it all down and struggle? So it can have impacts on quality and safety. It can lead to dissatisfaction with, I don't want to do this kind of procedure because I'm not comfortable doing it or I'm not very good at it. So electing not to continue to do those things in their practice or pursuing that kind of practice. It can be misconstrued by the faculty, by the assessors, as poor performance. And this is hypothesized to possibly account for some of the gender differences that are seen in performance, particularly early on in trainees, and also the decreased confidence that women have in early learning. This can lead to gender-based endorsing or perpetuating of gender-based discrimination and perpetuating these disparities, as well as having, as we've discussed, risk of pain and injury, and impacts on wellness, job satisfaction, burnout, and the selection, quality, and duration of overall surgical practice. So what's my ask of you after this sort of introductory tutorial is to try and understand and teach ergonomics. Last year's fellow, every other second I was saying, what's your left hand doing? This year's fellow is much taller, so every other second I was saying, do you want the bed up? Do you want the bed up? Do you want the bed up? Establishing a culture promoting physical health. So, not only encouraging wellness outside of the operating room, but encouraging them. Is the monitor where you want it? Do you need a step stool? Making sure that the OR staff is accommodating. If somebody needs a step, making sure that they have two steps locked together and all the rubber feet are on them. So optimizing the environment for the learner when able. Now, this is challenging. If Jesse and I do an open case together, I have to be able to see. I have to be able to assist him. So probably I'm going to get up on a step and he's going to stoop a little. We're going to kind of meet in the middle. But when you're able, when the fellow's sewing, he puts the table where he needs it to be. Establishing these external signals for breaks and posture checks. So, considering the every half hour sort of pause for stretching. I'll circulate some of the stuff from Mayo about, the quick stretching. Recognizing these anatomical limitations of specific learners, that not everybody's body is designed the way yours is per se, and that they might have needs that you could accommodate. And please consider adapting to these things. I know not everybody has seen a left-handed gallbladder dissection, but it's not rocket science. You could probably work your way through it, and and, let them try. Be flexible with instrument choice or surgical approach if you can, to try and accommodate the people who need the accommodation. And then, very importantly, encourage mentorship from similarly abled surgeons. I know it's very difficult for a right-handed surgeon to imagine how a left-handed surgeon would do things differently. But for those of us that are left-handed surgeons, I think there's some advice that we could give to left-handed residents. And so I have talked to a lot of them about a lot of these things, about how they can optimize their experience. Um, Support efforts if you ever are invited to participate in a panel or a trial or research around equipment, or if your institution is in the modality of buying equipment, please try and optimize equipment for all surgeons. So suggesting that there are laparoscopic handles out there are open instruments out there are endoscopes out there that are designed, not as one size fits all, are designed for smaller handed folks, and that they should be accommodated as well, especially since these days about 25% of the general surgery practice, general surgeons out there are female, but almost 50% of trainees these days are female. And since a lot of them have smaller hands, that we're not a tiny minority anymore. We're a pretty good chunk of the population, and we should be accommodated. And then please encourage trainees to report any injuries and get treated. The program, in support of their wellness, will absolutely ensure that they get to their physical therapy and they get treated early, and they can all get their, handout from ortho for shoulder exercises that I do every morning. And then specialty specific disability insurance. I think this is an important piece that residents who are generally broke don't think about things like disability insurance. But once you have developed a work-related musculoskeletal disorder, it is significantly harder for you to get specialty specific insurance. And that specialty specific insurance, for those who don't know, is basically a disability insurance policy that says if you are unable to do the job that you are doing now, if you are unable to be a bariatric surgeon, they pay your salary, the difference in your salary, to what you were trained in. As opposed to a general disability policy, which says, well, you're still a doctor, you can work for an insurance company. That's a huge financial hit after being punished for, workplace injury, because you can't operate anymore. So it's important that they do it early before they have medical problems of age as well as medical problems of work. And so encourage them. The American College of Surgeons has a nice specialty specific disability insurance policy that's pretty easy to get. And so that is my ask of you, and that's all I have. Can I take any questions or comments?
Hi, Christy. Can I ask you a question?
Of course.
Good morning. Thank you very much for actually bringing this topic, and it's very fascinating talk. Talking about surgeons' comfort and ergonomics is something somewhat, forgotten topic, and especially administration maybe is not necessarily thinking about, as long as if you're doing more cases, maybe then it's important, but otherwise, your comfort and ergonomics is not as important for other people as it is for us, especially. So I'm probably sure that you know what I'm going to be asking about, but robot versus laparoscopy, and being myself a laparoscopic and robotic surgeon, I personally really feel the difference, a significant difference in regards of ergonomics and comfort, laparoscopic versus robotic. I remember doing duodenal switches, laparoscopic, and if I do 2 duodenal switches a day on a patient with BMIs 60, I would be wiped out after laparoscopic operation for sure. And when I started actually doing, fully robotic, I could actually go and play pickleball at night, actually, after these two cases, right? So my question is, so do you believe that, optimizing laparoscopic ergonomics can achieve similar levels, of comfort and precision as the robotic systems can? Or do you think it is just inherited advantage of robotic console setup? because you can eliminate all these differences you talked about, like, hand size, height of the surgeon, left, right hand, and things like that. All of that is eliminated basically with robotic systems.
Actually, there's some literature on that, and I'll tell you a story. I went to give a SAGES course once, and I can't remember what it was on, and somehow I got assigned. I was on robot. It was on duodenal switches, and I got assigned the lecture on robotics. I'm like, I'm the last person who should be giving the lecture on robotics. But after looking through the literature, I said, and so it should be better ergonomically. And interestingly, like all of the robot surgeons in the room said, robotic surgery does not eliminate ergonomic problems. I think a lot of it depends on your attentiveness to it. Like I showed in the picture, there's some literature now that robotic surgeons also have neck and back pain, which is probably related to posture. It's probably related, we have one chair, right? Like you sit in that chair, but then Aruj sits in that chair. Are her feet on the floor? Is the chair at the right height? Is the teaching console optimized for where it needs to be? Also, how many of you have ever seen a trainee redo the little Velcro things around the fingers, right? That's important because that extra movement in there, um, that the way the little Velcro things are put together is designed kind of around your average surgeon and not around specific surgeons. So paying attention to that kind of thing. And while yes, the robot is better in that you're not working against the tissue. So the grip strength is reduced. There is still a difference between grip strength in the robot. Like you have to, do the pinchy thing. And so there are still reports of, and you have more wrist motion. So there are reports of ergonomic issues and workplace injuries, kind of more like carpal tunnel stuff rather than shoulder stuff. So you're kind of trading one for the other. I think Garrido had his hand up first. Chipman, I see you.
Hey, Kristen, thanks for the talk. It's something you rarely hear about. Just three quick things to plug. The first is the positioning of your head makes a big difference. I looked into this when I started having issues with my neck. If the actual weight of the head changes dramatically by the angle that you have, how far down you are, or how bent your neck is. So from some a report by Jerry Maguire's future son. The human head weighs 8 pounds, but it's actually a little bit more. It's about 10 pounds, but it goes from being about 10 pounds in a neutral position to at 30 degrees, it goes to 40 pounds, like the weight of a 5-year-old kid on average. And if you go to 60 degrees, it goes to 60 pounds. So that angle is a measure, it's a formula involving sine. So it's a nonlinear change. So just be aware that that even small, tiny changes in how you angle the bed, how you put your position can make a big difference. You don't have to make big changes. Second is, personally, I had issues. I definitely have issues with that, with weakness and numbness in my hand. And there are things available that are helpful outside of the talk, this talk, including the one that I found that definitely worked for me is called Neck Spine. It's not cheap, but it's basically a backpack you wear, and it goes underneath your scrub, underneath your gown, and it has a pole that goes up the back. It looks a little bit strange, but it hooks up to the headlight, and I think it's made a huge difference for me. And then the last thing is just put a plug. It's not related to this, but we're talking about patient safety. I'm a big believer in double gloving. I know it's a separate issue, but you really reduce your risk of getting the patient infected, you infected, and the change. I did it for anastomosis. I thought it was going to be a huge thing, and it really happened like in the span of like 3 cases, honestly. And then I didn't think about it ever again. And when you do that, putting a larger glove on the bottom, even smaller glove on the outside can make a difference. And that's all I got to say. Thanks for the talk.
Yeah, I would also endorse that plug. It's a AORN, not my favorite organization, but it's also an OSHA recommendation to double glove. And if you look at the statistics around transmission of bloodborne disease, wearing 2 sets of gloves dramatically increases transmission. So while it's very, very challenging to convince attending surgeons to change their practice, for the trainees who are learning, now's the time when you can help them design their practice. So I very, very strongly encourage all residents, all medical students to double glove, because now's the time that you can, sort of beat it into them. and it may prevent, HIV or hepatitis down the road. Also protecting, we all, stick ourselves or tear our gloves or whatever, and so that contaminates the field, so it decreases that risk. Candace.
Uh, Really quick question to that point. Did you see any literature on the orthopedic glove versus the double glove? Because the orthopedic glove is much, much thicker than a regular single glove. But I tend to like the ortho glove because then I don't have to do the double glove and then the glove is sliding on me. So question about that. And then my comment was that when I was a resident, I had significant neck pain when I used to operate with surgeons for all the reasons that you mentioned. And it actually forced me to definitely not even consider cardiothoracic surgery. And people used to joke and tell me, oh, you're working on your C-spine fusion, because of the way I used to hold my neck or hold my position. But I was forced to do that because the surgeons would never allow us to move the bed or change anything for us. It was always like, and that obviously was old school, but it does still happen today. So I wanted to say that. I'm more of a robotic surgeon, and if I don't have that robot in the right ergonomic space as far as my neck, my arms, and I'm also shorter. So my chair height has to go up, and sometimes the chair height doesn't go up high enough, or the table part of the robot doesn't go far down low enough. So there are still significant things, even on the robot, that do affect. I do still find that it is better for me to do robot than lap. Once I do lap, within the first hour, the back of my trapezius muscles are absolutely burning. And sometimes I have to have nurses rub them just because of the way, even if I adjust the table. So I just think like it's definitely important to consider for both, no matter what you're doing. I don't necessarily think robot is going to be the be all end all of surgical ergonomics, because you do have to make changes for both. And I just wanted to make sure I said that. And then the other thing is the fingers and the hand. So I was joking with G one day, and I said, sometimes I wonder if I traded a better body for arthritic hands. Because if I'm doing a case that I'm very, very stressed about, or I don't notice it, but my hand almost cramps and it actually has to be physically opened up with my other hand because it's been stuck in that position for so long and I'm not thinking about that. And so now what I do several times throughout the case, I make it a habit, just kind of very similar to what you mentioned about taking the breaks. I actually stop and stretch my back, and I also like work my hand to be sure that I'm keeping loose in that way.
There you go, G. An endorsement from a robotic surgeon. Jackie.
Hi, great talk, Christy. Thanks so much. I started to become a bit more aware about this last year when I was pregnant, because I actually started to develop pretty significant upper back pain, which I think just the change in my ergonomics kind of unmasked. But I just want to make a plug that as far as like exercises and whatnot, like doing yoga can be very helpful, because when we're hunched over operating, we're stretching our rhomboid muscle and that leads to weakness. So doing exercises that like where you're activating that muscle group can be very helpful, such as yoga. And then chiropractors, in addition to physical therapy, can also be really helpful adjuncts to helping treat musculoskeletal disorders, or seeing an osteopathic physician. And so there's some other docs and people that can also help with managing this. This is a big topic in vascular because of the weight of the leads, as Dr. Garrido has mentioned, weight of the loops and the lead we wear. Different lead, depending on how it's cut, puts the weight on different parts of your body. Mine's actually different than Fromer's, and so mine puts the weight more on my hips. But I try to, like, one way you can do that if you are going to be doing a combined case, which is probably less common for general surgeons, but just wear lead for the part you need the lead. You can always rescrub and decrease the amount of hours you're in lead. It can be really helpful. Different lead has different weights too when you start getting into custom fits. And then decreasing even the amount of time you're in loops, and adjusting the height of the bed is a great thing. And then I also I let certain residents sit if we have a big height discrepancy. Like they can sometimes actually have equivalent exposure. I know we keep bringing up Jesse because he's like an outlier, but Jesse sits while I stand. It puts the table at a good height for both of us, and he's able to do the case. So we just try to work through it. And I always I think being short, I kind of am more aware of this. I always, like when I have another petite resident or we have a height issue, I just kind of invite the change that needs to be made, and say, okay, do you want to get a step stool? Do you want to the table up? Just to kind of make it welcoming for them to actually speak up about this issue. Because I know I struggled with it at times because I didn't speak up enough when I was younger.
Yeah, agree. Thank you. I do the same. We don't wear lead. I never wear lead, but I have them break and put the lead on when it's time for a cholangiogram, because sitting through the whole case wearing lead, I think, is unnecessary, especially since our lead is old and heavy and generally pretty gross. Like, it doesn't get cleaned very often. So I agree with that. Is sort of only those things that make it harder, only use them as long as you need it to be harder. Dr. Butler makes a very good point in the chat about bedside procedures, to put the bed where it needs to be, put the rail down to make them more comfortable. But my caveat to that would be then they have to know to put the rail back up and put the bed back down before they leave the room, because otherwise it's a patient safety issue. All right, any other final thoughts? We're a little over time here. All right, everybody, thank you for your commitment to our trainees, and we'll see you next time. Have a great day.